3, 2, 1.
Shall I wait a few more minutes, or shall I start?
I think probably just give it 1 or 2 more minutes.
Okay, fine. Okay, I'll probably start now. Welcome everyone, welcome to this EMIS live event with ARC Health. My name is Zubair Ahmed and I'm going to be speaking about how to perform diagnostic enabled virtual ward rounds into care homes. So I'm a general practitioner by background and co-founder and CEO of ARC Health. I'm joined by Dr. Gupta and Dr. Safwan Patel, who are both also GPs based in Leicester, and they've been using ARC technology for a couple of months now in providing healthcare into care homes. And they're going to be speaking about their experience of virtual ward rounds and how they're using ARC Health technology. So we started ARC a couple of years ago to really combine the advantages of online healthcare provision with offline healthcare provision, to give clinicians the ability to make safer and better clinical decisions. with examination. So we've done this through developing something called the ARC station. As you can see here, it's a remote clinical examination station, which allows an instant two-way communication to happen between the clinician on one side to the patient on the other side. So the clinician can have a normal video call with the patient, but in addition, the clinician can carry out remote real-time examination on the patient. So the doctor, nurse, pharmacist, or paramedic can listen to the patient's heart and lungs, take oxygen levels, look into the patient's throat, look into the patient's ear, take blood pressure, take measurements to exclude sepsis. It works quite simply. On the left-hand side here, you see the ARC station installed in a care setting, in this case, in a care home. On the right-hand side, you see the doctor consulting with the patient through the system. And as you can see, the doctor just needs a normal laptop in order to make that connection with the ARC station. We were featured on BBC, on the BBC a couple of weeks ago. And one of the main things that came out from it with the interview with the doctor was the doctor felt really appreciative that she could listen to the patient's heart and lungs, look into the throat, look into the ear, and make a proper diagnostic assessment rather than just relying on a remote video conversation on the phone. So of course with ARC Health, there are multiple use cases. The stations can be installed in multiple care settings. They can be installed into care homes, into hubs, out-of-hour settings, and also GP surgeries. For this presentation, we're going to be, of course, focusing on the care home side of things, and we're quite lucky we're joined by Dr. Vinay Gupta, Dr. Safwan Patel, who have both been using this across their surgeries. Over to you guys.
Okay, so thank you very much for that introduction, Zubair. It's a real pleasure to be involved in today's event and being invited, so thank you very much. So as Zubair mentioned, my name is Dr. Vinay Gupta. I'm one of the GP directors at Willows Health in Leicester and Leicestershire. I'm very pleased also that my colleague, Dr. Safwan Patel, has joined us today. And really, I would describe him as very much the hub of our organisation in a lot of different ways, but very much regarding being the care home lead for Willows Health. And actually, along with a consultant geriatrician in our group, Dr. Richard Wong, very much the lead for coordinating the overall care for older people within the patient population we look after. So we just want to give you a bit of an idea, a bit of a guide to the journey at Willows Health in terms of managing our care homes and how we've actually very beneficially used ARC as a way to achieve good quality and timely patient care. Just to understand this a little bit better, I think a bit of context first of all is really useful. So as an organisation, Willows Health, we're the largest provider of primary care services in Leicestershire. We have a group of 7 practices which are distributed across 9 different sites, and we're really proud to serve over 40,000 patients across 2 CCGs, namely the Leicester City CCG and the West Leicestershire CCG. In terms of leadership, we're led by 6 GP directors, all of who have varying interests and experiences. And I think it is probably worth noting that one of my fellow directors, Professor Rishabh Prasad, is actually a professor in digital health and is actually the co-founder of a digital health unit within De Montfort University in Leicester. Naturally, he had a very large role to play in terms of the actual use and implementation of ARC. Focusing, as Zubair said, very much on the care homes today. So which care homes do we look after? So we actually have a very significant cohort of care home patients, as I'm sure Safwan will kind of agree to. We have approximately 400 care home residents we look after, and they are across around 40 care homes in the city and the county. So really very quite significant cohort of the overall patient population. So moving on, what is our real kind of vision in terms of the service we want to provide to the care homes? So I think very much we've tried to use an MDT model approach of care, which has been largely GP and more recently consultant geriatrician led, with the appropriate support, of course, of allied healthcare professionals and administrative staff. I think what we're trying to really assure is that we can really give very good holistic assessments and personalised care to patients 5 days a week, and of course at any time that we are open. This has been greatly supported by a dedicated on-call doctor dealing with care home queries, which is often Safwan himself, and as well as the services of the consultant geriatrician and acute medical physician in the group I mentioned. And that's been quite invaluable to actually try and avoid inappropriate hospital referrals and admissions. So in order to really understand how ARC has fitted into this model, and I think greatly enhanced it and improved it, I think let's think about some of the challenges that we faced in providing this service in the first place. So with a large number of homes, locations and the geographical distance between the homes, naturally on a daily basis, this really did generate and still does generate a large number of requests and queries, all of which naturally take quite a bit of time to handle appropriately and deal with appropriately. The complexity of some of the older and sometimes more frail cohort of the care home residents we look after has also provided a challenge to care. In terms of the sheer practicality of arranging home visits from a resource point of view, I mean, the large number of care homes and the geographical distance between them would often be a real challenge, and along with the other daily duties that needed to be done within general practice day to day, I mean, I think that posed a real challenge to how we could actually do all of this with the resources available. One thing that's not on the slide, but I do think is very valuable in mentioning also in terms of its impact, is the ever-changing workforce that I'm sure we're all aware of we're experiencing within primary care. You know, the emergence of a much larger locum workforce who sometimes won't be able to deliver home visits or, you know, don't wish to deliver home visits as part of their contract, and less regular partners and regular doctors within the practices and organisation. I think that's really impacted the continuity of care for this complex group of patients, and often meant sometimes there were simply not the resources to adequately provide physical visits to patients in a timely manner, particularly in the care home setting. The last point to mention, I think, is not only very valuable, I think it's important to understand in the context of, obviously we're quite a large organisation serving multiple care homes, but even for smaller practices or smaller size practices, or even for individual care homes, I think the last point I'm going to mention is very valuable as well. And it's actually the inevitable time delay that would often occur for treatment to acutely unwell residents within care homes. This is where I feel ARC has absolutely added the most value in a lot of ways. So if we think about the more traditional model of care that we all have been quite used to practicing, medical attention or a visit, it often have to be delayed until a clinician had finished their morning duties. And actually, there's a real theoretical possibility of a patient deteriorating in that time frame. With ARC, and something Safwan I'm sure we'll mention a bit later on, we've managed to really address this issue very well. And the resultant outcome, I think, has been very satisfied carers, clinicians, and above all, really patients and their loved ones. So looking at these challenges, this is where Zubair and his team at ARC have really helped to bridge a lot of these challenges and address a lot of these. And we managed to install 8 ARC terminals into 8 different care homes in Leicestershire in April 2020. Now, needless to say, this was at the height of the initial COVID outbreak in the UK, which undoubtedly really did exacerbate many of the challenges that we already faced. Not to mention, of course, the undoubted increased significance of having strict infection control measures within care homes and a large number of care settings. So our experience so far, and shortly I will be handing over to Dr. Patel to give some examples and provide an insight into ARC's operational use. But just on a broader level, what has ARC allowed us to do so far, and how has it benefited us and allowed us to deliver better and more efficient care? So I think it's very much allowed us to engage in virtual ward rounds for care homes, as well as to manage the acute need that arises with looking after the number of care home residents in the number of different locations that I mentioned. In terms of real-time objective examination capability, this has very much allowed us to also in the process ensure clinical safety and very much enabled quicker access for healthcare to both patients and carers. From a safety point of view, it's mitigated infection control risks very largely, and that's naturally been absolutely paramount during the COVID outbreak, but I do feel that will continue to be a very strong consideration in the future. The reduced need for actual physical home visits in the more traditional model of care, because we have ARC available. I think that what that's allowed us as an organisation to do is really more efficiently and more effectively manage our resources within primary care, as well as actually appropriately prioritising the care home residents' medical needs according to clinical need. So this is very much the point where I'd like to hand over to Dr. Safwan Patel. As I said, he's very much the hub of our organisation day to day. He's going to give a bit of an overview of the operational use of ARC on the ground and some very interesting case studies and examples since we started using it. So over to you, Saf.
Thank you, Vinay and Zabir. So my name is Dr. Safwan Patel. I'm one of the home visiting leads and the lead for the Willows group. Now, what does that involve? That basically involves managing patients in the community across the whole of Leicestershire. Now, we have multiple different sites. The social economical background of these patients is different. The care homes are in different locations. However, they are all patients. So we have to provide a care for them. Now, prior to the ARC device, I was using primarily the phone to contact the carers, patients, and assess them over the phone. Occasionally using a video calling if I wanted to see something. However, since the ARC device has been introduced, it has completely changed the way I work. So I've been using ARC for about 3 months now, and working closely with the care homes, we have found that it's worked really, really well. Now, the reason why it works well is because it's quick, it's efficient, and it's friendly, which means that I can provide patient care directly to the patient, liaise with carers, nurses, healthcare professionals at point of use rather than any delay like Dr. Gupta was talking about. And the patients and the carers and the staff are very, very thankful for it because they've never had this sort of service before. And this service has only been available because of the ARC device that we have. Now, initially, when people first start using technologies, they are a bit apprehensive. However, I can assure you, it has only improved patient care and quality of care that I could have provided. So in doing so, I use it on a daily basis. I pretty much use it in the care homes that I normally use it with and do a virtual ward round. So prior to before the COVID, I've been using this product to do daily ward rounds for acute patients, for examining them, to follow them up, to provide any carer support, nurses support. So it's not only to examine the patient, but it's to do with providing holistic care for all patients. Because in most cases, we sometimes have to treat the family, friends, carers, as well as the patient and make sure that the plan is amenable for them all. So I'll give you a few examples of patients that I use this on. So the first patient is a mental health patient. You'll be wondering why a mental health patient. Now, the first thing is I use the Medix ARC device for all my care home patients, not just those that need to be examined, because having a face-to-face consultation with a doctor really improves patient concordance to medication and also the experience that they have as well as the carers. So this was a patient who had a deterioration in his mental health. Now, I'd spoken to the care team and he was already under the mental health team. So I asked them to contact the team to see if they can get him reviewed. The community mental health team refused, saying they want a physical examination of the patient. So that wasn't a problem. They contacted me via the ARC device. On the spot, I was able to take a full history with the video calling device, take the temperature, blood pressure, use the stethoscope to examine the chest and the heart to make sure the patient was physically well prior to referring again. Now, my examination and history taking concluded that there was no physical illness causing this acute deterioration in his mental health. So the community mental health team were quite happy to accept the referral. So in this case, number one, a home visit was avoided. So it freed up clinician time to do other things. The other thing is it prevented any delay in the community mental health team seeing and treating this patient. So those two both together is a big thing. Now, the case study number 2, skin lesions. Prior to the ARC device, what I would do is I would ask carers to maybe email in as pictures of lesions that they were worried about. Technology is a massive issue inside care homes, as a lot of the carers don't like to take photos. Also, because of patient confidentiality, it can get difficult. However, in this case, with a 79-year-old chap, the nurse was concerned about a rapid growing lesion on his left shoulder. Now, they use the term malignant melanoma, so this nurse was rather concerned. Again, all I had to do is log on to the ARC device. I took a history about the lesion where I concluded that actually it wasn't a rapid growing lesion. It'd been there for many years, but a new carer had come in and was concerned about it. I used the Medicam. Now the Medicam is a special high definition camera. So it's not a simple camera that you'd get on your iPhone or in a Samsung or something like that. This, at the distance of between 2 and 7 centimeters, gives you a high definition image of the actual lesion in real time. So I can ask the carers to move the camera, adjust it according to my needs so I can review the lesion. Now this lesion was just a basic seborrheic dermatitis, and a new carer was concerned about it. Prior to ARC, I would have had to send a clinician out as there was a concern of malignant melanoma. So number one, the home visit was avoided. And number two, the patient, as well as the care staff, were very, very happy with the service that they received. So they could move on to dealing with the next problem and the next patient they had, and this was dealt with quickly and efficiently and friendly way. Now, case study number 3. Now, this was an 81-year-old chap who had a change in his behavior, and prior to any referral, I decided to just do a medic spot examination or a consultation just to make sure there was nothing going on before we referred him to the community mental health team if needed. Now, in this case, the carer said, oh, he's been getting a bit confused, he's not listening to us properly, he just seems a bit agitated. Now, the word agitation is very vague sometimes. So on taking a further history, this patient was not confused. This patient was probably a bit hard of hearing. So I thought, let me examine him. So I did a basic examination with his observations and so on, and they were all fine. But I used the Medicam with the appropriate cover to look in his ears. And it was clearly evident that he had impacted wax in both of his ears, which was probably in turn affecting his hearing, and then leading the carers to conclude that he was confused and agitated because he couldn't hear them. So number one, a home visit was avoided, so it freed up clinician time. Number two, the underlying cause of his query agitation was identified. Now, he was treated and he was fine, but prior to ARC, most clinicians probably would have thought, is this a urine infection? Shall we treat him empirically? This avoided any overtreatment for the patient and avoided antibiotic treatment unnecessarily. Now, the last patient I'm going to discuss is probably the most interesting patient of the 4. So this patient, I had a phone call from the care home. She was a 99-year-old lady. Carer was concerned because she became acutely short of breath. Now, this was just at the start of April, just when COVID was coming in. It wasn't rife in the care homes. There was a lot in the media, but nobody really wanted to admit that they could possibly have a COVID positive patient, and there was no testing available at that time. So prior to ARC, all I could do was do a video call to see this patient. I reviewed the patient. She was short of breath. I did some basic observations with the carers, so the temperature was up. She was a bit tachycardic, but she was very comfortable. Now, I reviewed the care plan with her and the carers, and we had an advanced care plan in place where she did not want to go into hospital unless it was life-threatening or if she needed supported care for any form of illness. Now, she was quite comfortable, so I accepted her staying in the care home with clear guidance and red flag signs to call me back if she deteriorates. I said to the carers she possibly has COVID, but there is no way of testing, so you isolate her regardless. And I prescribed her with some antibiotics just in case this was a run-of-the-mill lower tract urinary tract infection and community-acquired pneumonia. Now, I arranged for a follow-up call just to make sure she was improving, just because she was short of breath, and by chance the ARC device was installed. So I thought, perfect opportunity to use it. So this time I did a video call with the patient, seemed much better in herself, carer and patient, both confident. She felt a lot more better. Temperature was checked, which was normal, blood pressure normal, heart rate normal, but this time she still had a bit of a cough that I could tell on the video call. So I used the stethoscope to auscultate her chest. So subjectively, she looked much better. She felt better. The carers felt she was better. Objectively, she still had crackles on her lungs, which meant that she probably still had an unresolved infection of some sort. So I gave her a second-line antibiotic, followed her up again a week later. She improved, but this time actually had a swab done and confirmed that she had COVID, which means that she probably had COVID pneumonia. We treated her appropriately. We had objective investigations and heart rate, blood pressure, temperature readings to say that she was improving, and she just celebrated her 100th birthday. So all in all, this patient was seen in the care home. We avoided a hospital, we avoided a clinician going out, and this was good because of, number one, freeing up clinician time to do other things during the COVID situation. Number two, we avoided the spread of possible infection. Now, me isolating her soon, as I did, probably avoided a massive outbreak in this care home. The other thing is, we were able to treat her appropriately. Now, if, for example, they had called me back and said that she was deteriorating, the only option I would have had is to call 999, and she was not for hospital admission unless really needed. So we avoided an inappropriate hospital admission for this patient. So this is a keen example of how the ARC device has really helped me. So in summary, I use the ARC device on a daily basis to do virtual ward rounds with my carers and my nurses, my nurse specialists and physios sometimes, so I can review the patient both via video call and using the extra devices that are part of the ARC device. But it has not only improved patient care, but helped me provide a better service to both patients and carers. And in a sense, I don't think I could do without it now. And the next question you're going to ask is, how many home visits have I allocated to any of my clinicians over all the sites since I've had ARC? 0. No clinician has been out to any of the care homes since I've had the ARC device, which means that I can use the device to examine any patient remotely at point of when they need to be reviewed without any problems. So I'll pass it back to you, Vinay and Zubair.
Thank you, Saf.
Yeah, thank you. So thank you very much, Saf. I think that not only really emphasises the benefits of ARC in so many different ways that I alluded to earlier, and many more that Saf mentioned, but there were some really good real-life examples of how we have actually used it to manage some of our care home residents, and really some very common presentations in terms of the cases staff went through that we often see in this group, and how they will manage very well using the ARC device. So just to sum up, looking ahead and where I feel that we are heading to maybe over the coming months and years to come, I think it's going to be vital to implement and use some form of digital technology to assist in clinical decision making in care homes. The use of ARC and digital technology will definitely allow for scheduled virtual care home ward rounds something which I know Dr. Patel is actually doing every day in our group, but also something that I really feel across the board will really benefit this group of patients, and very much also in keeping with the recent care home DES that's been rolled out as well, and this would really help to facilitate that. For our group, the use of ARC has definitely allowed us to allocate resources much more efficiently, and this has naturally had a very beneficial staffing and resource implications also. Finally, I really sort of look forward to engaging in digital health initiatives, which will allow us to really encourage and allow us to proactively monitor care home residents. And I think this will lead to more timely interventions. And something else that's very much a passion of the group is very much to encourage personalised care planning for care home residents and facilitating better continuity of care. And this is something that I think ARC will very much help to facilitate across the board. All of this, ultimately, obviously we want it to lead to better patient outcomes and increased carer and clinician satisfaction in the long run. And I think even in the short time of using ARC, it's already starting to realise a lot of these benefits. So thank you very much for listening, and we'll pass you back over to yourself, Zubair.
Thank you, Dr. Gupta. Thank you, Dr. Patel. So I'm going to switch my screen just so we can do a demo. Hopefully this will work. Fine. So you should be able to see my screen now. So this is the clinician interface. A clinician would log on through a Google Chrome browser. It's a two-factor authentication. Once they're logged on, they will see we will see there's a patient waiting at this particular care home. The patient's been waiting for about 30 seconds. So as a doctor, I would click on the patient's ID, assign it to myself, and then I will join the consultation. Hello, Martin. It's Dr. Ahmed. I'm one of the doctors working for ARC today. As you can see, it's a two-way video consultation with the patient. And of course, in a care home setting, the carer is with the patient as well at the same time. So we have the patient details on the left-hand side, and then on the bottom side of the screen, we have different examination capabilities. So Martin, I would like to listen to your heart. So if you could pick up the stethoscope, please. So as you can see there, and if you just put it on position B of your chest on the left-hand side. Perfect, that's nice, clear heart sounds. And now I would like to listen to the left side, left base of your lungs, please, if that's okay. So you move the stethoscope onto the left-hand side, just at the bottom side of the ribs, and take a deep breath. And out. And again. And out. Now, thank you, Martin. So you might not be able to hear that because it's running through our system, then it's going through Microsoft Teams. But the heart sounds and lung sounds are very, very clear. And in fact, we can filter out heart sounds and lung sounds to make the quality even better. We can also capture heart and lung sounds. So if you do feel as if something might be a murmur, for instance, you can take a audio clip of it and keep them attached to the records. So in addition to the stethoscope, we have something called a Medicam, which Dr. Patel has used a few times. So say I want to look into Martin's ears. So Martin, can you please pick up the Medicam? Of course. Thank you. And if you put the And let's look into your left ear, please.
Okay.
Good, and move it around. There we see for clinicians in the group, as you can see, very nice, healthy looking tympanic membrane. And again, I can take a picture of this. And this picture can be seen on the, after the consultation. Thank you, Martin. Let's see, you have a bit of a sore throat. Let's look into the throat. We can do that with the same camera. Say ah. It's a really good view of the pharynx at the back. Of course, for care homes, doing a lot of times we have to go out for care home visits are for respiratory illnesses. So we also got a pulse oximeter, which is integrated. So here we can see Martin's finger in the pulse oximeter. You can see his pulse is 69, his saturations are 96. And this is functionality which one just doesn't get with a telephone call or a mobile smartphone call or video call. We also have a contact with a forehead thermometer, which Martin can touch on his forehead and press the button and show it. Yeah, perfect, thank you. And we also have a normal blood pressure machine, which we don't need to demonstrate really. For all of these different devices, we have instructional videos. So here's instructional video for use of the stethoscope, for instance. And of course, these kind of instructional videos really help the carer as well. And we do train the carers when we install the station, so the carers are comfortable using the different examination capabilities. So here's another instructional video on how to show the skin. So this is how Dr. Patel had excluded a malignant melanoma by using this device. And that's it. So once we've done the consultation, the clinician can click end consultation. Thanks for your help, Martin. Bye-bye. And we can click end consultation, and that's it. And then we can go back to the waiting room, and we can see there's no other patients waiting to be seen. So at this point, I've done a real-time video consultation with the patient, but importantly, I've also examined the patient. So we've listened to the heart and lungs, we've looked into the throat, looked into the ears, and very vitally, we've taken basic observations, which are of course very important in all age groups, but especially in the elderly, where we need to make sure they're not deteriorating. And that's fine. And we can now switch back to the presentation. And we'll just take questions now, if that's okay. So I think we can ask questions at this point.
Zubair, the question is published. Do you want to read?
Sorry?
The questions are me to read them out?
Yes, if you can read them out.
So the first question is there a funding stream for this?
Rahul, do you want to take that one?
Yeah, of course. So hi, I'm Rahul from Arc Health. Today, the technology can be funded from two streams. One is from a CCG perspective. There are available funding streams for the COVID response, and Arc Health technology has been put in place as it avoids infection risk as well as improves efficiency. So there's an ongoing benefit. The second, in a primary care setting, such as primary care networks or GP federations, find that because of the cost saving in managing a care home setting remotely, avoiding travel time, it pays for itself, just even by avoiding just one locum session a day. So those are the two streams that we see usually, but please do reach out to us and we can discuss your specific scenario. The next question is, have any hospices taken up this technology in your area?
We've not installed any of these in hospices, but that may also be quite a good use case. Of course, I don't know if Dr. Patel or Dr. Gupta, if you have any experience of, if you have any thoughts on this.
So there have been cases when patients may have ended up in a hospice, but because of ARC, after discussion with a specialist in the palliative care team, we've avoided admission into the LAROS or the hospice. Because as well as it is a palliative care place, we have had patients during the COVID situation that have passed on, not because of their actual underlying condition, but because of COVID. So we try to avoid admissions into COVID. So we've stopped admissions into palliative care settings with the ARC, but we haven't had any ARC devices put into the hospitals.
Hospices.
Thank you, Safan. So Zubair and Ashley, Safan and Vinay, I think the next one is for all three of you. How will you overcome training and building confidence in residential homes? So perhaps you could talk about how you've done it.
Shall I answer that one?
Okay.
Yes.
Yeah. Yeah.
Okay, so initially there's always apprehension in all care homes. So I'm the main user of ARC devices inside Leicestershire. So initially there was some apprehension in using it. However, practice makes perfect. After the first use, a carer has usually become very confident in using the devices, especially because the videos are there, which are idiot-proof essentially, where you can just literally press a button and it shows them how to do it, and then you can see the actual picture easily. So they have found the instructions very easy to follow, and I have found that applying the instructions or showing them the instructions are very easy as well. So it just is practice. They don't need much training at all. I've actually personally trained some of the carers that were not there for the initial ARC kind of presentation, and we use it on a day-to-day basis, and there is no issues at all.
And I can maybe let Vinay, Dr. Gupta come in. We're also working with De Montfort University to develop a training package for the carers, and Dr. Gupta might expand more on that.
Yeah, absolutely. So I think it's probably sort of twofold. Very, very valid question, actually. I mean, obviously, with any form of digital technology and with any form of doing such things, obviously it is very much dependent often on user confidence and user comfort of actually using it. And as Safwan very correctly said, naturally when you initially bring anything like this in any care setting, there might be a degree of apprehension. I mean, one thing that really is helpful is how easy it is to use. So I certainly know when Zubair demonstrated it to us initially, and one of the big reasons why we very much thought it'd be an excellent idea is because it is so easy to use. And as Zubair very nicely demonstrated, when you're actually using it, there are a couple of very helpful video prompts. In terms of more formal training, what we're currently developing, and it's something Zubair just mentioned, actually a more formal training package which will have CPD points attached to it for both carers and clinicians. Now, how we're doing this is we're very much trying to make it a dynamic process. So, as I mentioned, one of our other GP directors is also the founder of a digital health unit with De Montfort University, and that's a conjunction between Willows Health and De Montfort University. So what we're doing is we're carrying out some qualitative evaluations at the moment of the clinicians and carers' experience of ARC. It's all been very positive, but obviously from a training perspective, we're trying to collate all the most useful things that we can put together in a really high quality training package. As I said, associated with CPD points also, so carers and clinicians can really hit the ground running. I mean, one thing that I think is really important, though, is actually remembering how easy it is to use. And as sort of Safwan mentioned as well, pretty much any carer of any level can use it very comfortably and easily. And even if you're thinking about it on the other perspective, the fact that actually we do have some of these in GP surgeries, and we have it in one of our GP surgeries. I know that's not in a care home, but in a surgery, the fact that patients will be coming in to use it with no prior training at all, and that still actually goes very, very smoothly, is just another kind of example of how easy it is to use.
Thank you, Dr. Gupta. Thank you, Dr. Patel. The next question relates to the appointment booking. So the question is around how is the appointment booking, how does the appointment booking happen, and how does a patient populate themselves on the ARC Health clinician screen?
Dr. Patel, do you want to take this one, how you do this in practice just now?
So because I cover a number of care homes, what I normally do is I ask the carers or the nurses to give me some prior notice of when they want to actually have the call or the consultation. So normally I have a 10 to 15 minutes. I have it logged on ready anyway, all the time in the background. So I know when the patient's ready to be seen, but I always ask them to just give me a call. They give me 10 minutes notice just so I finish up what I'm doing, and then I can just jump on and the consultation can start whenever they're ready. So for example, this morning I had a phone call saying, okay, Dr. Patel, are you working today? And I said, yes. Okay, can we do a consultation? What time will you be free? And I said, okay, let's do it at 10 o'clock. That way you guys would have finished your ward round, doing your meds and so on, so we don't get interrupted. 10 o'clock, consultation done, finished. Within half an hour, saw a few patients and they were happy, patients were happy, everybody's treated in a quick, efficient and friendly manner.
I think, of course, going forward, we are working on integration with EMIS and other PMR systems, so we will be able to, book our patients directly into the PMR system as well. But just now, there are lots of ways we can still continue without that.
So it's operator dependent, depending on how the operator feels is best for them. But generally speaking, if you set a time and you both can have that consultation, you can do the timings yourself, you can do the appointment yourself, you can put it on the ledger if you want, saying you're going to do ARC consultation at this time for this patient. So for me, it personally works out easier because I'm quite comfortable with the care homes calling me the way they do, and because I have a good relationship with them, it works.
Thank you.
Yeah, I mean, I think also, if you don't mind, just to kind of add to that, what I would say is in the care home sort of setting, sometimes that actually works tremendously well, simply because, as I'm sure, if you're associated with the care homes, unexpected things can happen. Actually, with all the less will in the world, even if you set a set time for these things, sometimes, as Dr. Patel, I'm sure will kind of agree with, sometimes they might have to say, well, actually, just give me 10 minutes because something else as an emergency has come up. And then, so you can actually make it very dynamic. And with the waiting room that's in place there, it means the clinician knows what's going on, but the care home also does. So I think that's worked very well.
Thank you. Zubair, you started talking about the integration with EMIS. Can you also expand on, there's a question around the data going straight into the patient records?
Yep, so just now the data doesn't go directly into the patient record, but we're working with EMIS to start this process off. So these the imagery which I shared from Martin's ears, the heart sounds, lung sounds, the blood pressure, saturations, So, you know, we'll get to a point where that's going to be automatically populated into EMIS. Definitely by the end of the year. But I think Dr. Patel and Dr. Gupta can probably attest, it doesn't really stop doing what we needed to do just now.
Thank you.
Yeah, absolutely. No, total agreement with that.
There's a question on, does the care home need an HSCN connection to use ARC? And I can answer that. No, it does not. Today, all we need is a strong internet connection at a care home and at the practice where the clinician is, or wherever the clinician is. And we also have network solutions to ensure that care home can be up and running whenever we need to. There's another question, Zubair, and I think it talks about, I think in terms of the product pipeline. So there's a question around the portable station, which mobile, a district nurse or a mobile clinician could use. So if you can talk about that.
Yep, sure. So we're going to have three main types of stations. One is the static station, which is for GP surgeries, which is in a static room. Secondly is a care home mobile station, which is mounted onto a trolley, which can be moved around with battery packs and can be moved around the care home. And third is a more mobile portable unit, which is about 5 kilograms, which someone can carry around. A nurse, paramedic, pharmacists, medical students, can carry around and conduct consultations with them on-site GP, with centralized GP support. So we're prototyping the mobile and portable station just now. So if you're interested, get in touch, and then we can share our designs with you. But it should be next couple of months. We'll have something ready to start rolling out.
Thank you, Zubair. So there's a question which I think would be useful for both Vinay and Safwan for you to answer, and Zubair. And the question is around the difference from video consultation. So many surgeries across the UK have video consultation right now, and some may also be able to get some observations from some devices that may be at a care home. What does ARC Health Station add beyond that?
For me, the main thing is the devices are calibrated, they're tested, and you have that stethoscope and the otoscope. Stethoscope, of course, so there's a lot of respiratory illnesses within care homes, and you can have more diagnostic certainty, and you can also safety net patients a bit better. I'll let Dr. Patel also elaborate onto that.
Sure, thanks, Zubair. So the main reason why I use ARC is, number one, it's consistent, so it's a calibrated machine, but the stethoscope and the high definition camera that it has, you can't get anywhere else. So if you were to do a WhatsApp call with the highest definition camera, you still can't listen to the chest. If you used a video call using a computer, you still wouldn't get the stethoscope. So the stethoscope is something that will give you objective investigations and results, so you can reproduce it on a daily basis, and you can actually see if there is any changes, so as a follow-up and so on. But another thing is for safety, for our safety as clinicians, this is auditable. So if, for example, you hear a heart murmur, like Zubair said, you can record that heart murmur, and you can also review it at another time. If you see a lesion on a tympanic membrane, if you see a skin lesion that you're concerned about, you could always take a photo and you can send it off to the dermatologist to double check and bounce off any queries that you might have. You can't do that with a normal phone. You can't save photos on WhatsApp. You can't send photos via WhatsApp. It goes onto the cloud. Data protection is compromised. So this ARC device avoids the data protection issue, as well as I don't know of any other service or device out there that will allow me to remotely listen to somebody's chest. So it protects me as a clinician as well.
Yeah, absolutely. And, you know, one thing I'd probably just add on that, and it's something that we've discussed at some length as well, Zubair, you know, the benefit of having that real-time objective examination of the patient compared to a simple video call is, you know, I probably can't emphasize that benefit quite enough, actually, because, you know, just with the cases even Safwan went through earlier, you know, I think it was demonstrated very well that additionality of having the stethoscope, the high resolution, kind of high definition camera, just having all of that and the ability to kind of, if you like you say, take photos or take pictures of relevant things or record relevant things which can then be followed up. It's something that's not available in the other video calling sort of methods, basically.
Thank you. So one question for you, Zubair, what are some of the additional devices that could be added on to this? What is the pipeline? Can you talk about that?
Yeah, sure. So we're working on integrating one lead ECG into the device, and also spirometry and peak flow, so we can start doing chronic disease reviews in care homes and GP surgeries, from pharmacies, from other settings. So those are the two extra devices we are working on integrating just now.
And then I've kept this question for the last. There are a few questions on how much does it cost?
Rahul, do you want to take that one?
Yes, so we have a structure where we charge an installation cost and an ongoing fee, which includes license fee. Our care home pricing starts from £500 of setup and £250 per care home for a license fee. But feel free to engage with us after the session, and we're happy to discuss pricing in more detail with you. So that's it. We have one more question, which has just come in. How often does the equipment need calibration?
Yeah, so the equipment is calibrated every 12 months, which we do, which is part of the contract.
Thank you. We have no more questions, so I think we can wait for a few minutes if there are any other questions. So there's another question on how is the station cleaned between consultations?
Yeah, so we have a cleaning SOP, and after the consultation ends, cleaning instructions appear on the screen telling the carer how to clean the equipment, what to clean. So it's all quite dynamic, and the station keeps a record and a cleaning audit of how often it's been cleaned. And it's impossible for another patient to use the system unless it's been cleaned before. And we also have a package where we can also, of course, supply the disposable wipes, and the wipes which have been recommended have been shown to fight against COVID as well.
Thank you.
And I probably, yeah. Sorry, Rahul, just to add to that, actually, on the infection control sort of aspect and the cleaning, it's going to form a very core part of the training package that we're doing with De Montfort naturally. This obviously is a very important aspect, cleaning in between patients, and that, but it's currently being done to a very, very high standard.
Thank you, Vinay. So just a quick clarification to my response. The pricing I mentioned is monthly license fee, which includes clinician licenses as well.
Yeah, so essentially, we have two different pricing models. One is if you want the station just as a single provider, or if you want to share the stations, share one station across multiple providers. But please, like Rahul said, get in touch, depending on what you want.
So we have no other question, but meanwhile, I can throw in one question. Zubair, you mentioned about 2 pricing models. Where all do you think this technology could work in the NHS? So we see care homes. Are there any other use cases?
Dr. Gupta, do you want to take this one?
Sorry, I didn't catch the question. It cut off. What was the question?
Are there any other use cases beyond care homes where you would see this technology being used?
Oh, absolutely, yeah. Okay, yeah. So certainly within GP surgery. So we actually do have one ARC terminal within our main site, our kind of headquarters site in Leicester, and we have been using it for that. So that's for obviously the more mobile individuals who can come to surgery, but again, and you know, can be examined virtually, and of course it adds a lot of benefit from that point of view. I think also sort of considering you know, some of the additions that are not only being planned for ARC, but that, you know, that potentially could be added on to the piece of equipment. I think actually, you know, and I'm certainly no expert in this field, but I certainly think there could potentially be a very strong role even for secondary care, from the point of view of if we could start thinking of chronic disease management by means of the spirometry capability, the 3-lead ECG that Zubair mentioned. Actually, a role might develop quite strongly within secondary care environments as well. But even chronic disease management within primary care going forward, again with some of the additions that are being planned, certainly that will be quite a strong use case for us as well going forward.
With the COVID pandemic, of course, one use case is it can decrease cross-infection. So you could have a GP consulting from one room and the ARC station being in the neighbouring room, so the doctor and patient don't have to interact with one another and to risk that cross-infection. So we've had this used in COVID hot hubs and these kind of settings as well. But of course, this is hopefully a short-term thing.
Mm-hmm. Yeah.
Thank you. I think there are no more questions. So Zubair, would you like to close with any remarks?
Yeah, no, thanks everyone. Thanks for taking the time out to hear us speak about ARC. I think the main thing with ARC is, of course, video consultations have a time and place, but in the vast majority of cases before COVID needed some type of clinical or physical examination, and this is even more acute in the care home setting. So with ARC Health, you can do a video consultation plus objective examination to essentially ensure better clinician decision making. You can diagnose with more certainty, and importantly, of course, for clinicians, we can safety net better, exclude red flags, pick up sepsis. We can do these things a lot better rather than just doing it based on subjective symptoms. And if you have any questions, get in touch with EMIS, who will be happy to support in your decisions. Well, thank you.